talented students over the last 2 semesters. We have been working very diligently on a project in conjunction with Dr. Melissa Richards at Winona Health. And then we're also awarded a special grants project through the Winona State Foundation. So lots of things came together to make this project happen. Before we get started, I'm going to have them introduce themselves.
I'm Jelena.
I'm Kayla.
I'm Ashley.
I'm Evan.
I'm Kaylee. I'm Megan.
I'm Emily.
I'm Taylor.
And so I'm thrilled to be here. We found lots of good stuff. I think they learned a lot in the process, and you get to hear all about it in their own work. They've put a lot of blood, sweat, and tears and no sleep into this presentation. So, without further ado, they are going to present on the effects of a resistance band training program on muscle soreness during pregnancy with limited intervention.
Okay, so there are many physiological changes that occur during pregnancy, and these affect all of the body systems. Some of these changes lead to concern about the safety of the mother and the baby during exercise. One of these concerns is hypoxia, which is a lack of oxygen to the baby during exercise. So in order to avoid this, we taught the women proper breathing techniques for each individual exercise. And research has shown that the body adapts to pregnancy by allowing an improvement in ventilation and peak oxygen pulse. Another big concern is hypoglycemia, which is a decreased amount of glucose and nutrients available to the baby during exercise. Research has shown that the body, again, adapts by having an increased glucose uptake, supplying nutrients to the fetus to allow it to thrive. Also, hyperthermia, which is an increased core body temperature of the baby during exercise. Now, there's been no evidence to suggest that this happens in humans during exercise. One of our last big concerns is the supine position. That's this picture down here in the corner. As we can see, the baby is on one of the main blood vessels in the body, and this blood vessel brings blood up to the heart, which pushes it out to the body. With the baby in this position, it prevents sufficient blood from getting back to the heart and out to the body. So we want to avoid this position at all times during pregnancy. Now, although there are many concerns about physical activity during exercise, it has been determined that the benefits outweigh the risks of aerobic exercise. So the American Congress of Obstetricians and Gynecologists, or ACOG, is a professional organization that sets forth guidelines for pregnant women. And they have a guideline about physical activity that states that all women should do 30 minutes of physical activity on most, if not all, days of the week. Most of our research is on aerobic exercise, but there are some potential benefits that research has shown for resistance training. One of these is that it is more tolerable for pregnant women than aerobic exercises. Also, the ability to handle the demands of labor and birth better, and also potentially a positive effect on musculoskeletal discomforts during pregnancy. While there are potential benefits, there is a limited amount of research on resistance training during pregnancy. One of these is that there is a lack of knowledge about the safety and appropriate methods for implementing a resistance training program during pregnancy. There's a limited amount of research on the effects of resistance training on muscle soreness after birth, and there are no current guidelines for resistance training during pregnancy. Now, one common problem that has happened in many studies is a decreased adherence rate or a low adherence rate. So one of these studies that we looked at had a group fitness class that had resistance training in these sessions, and only 46% of the women participated in 100% of these sessions. So we wondered if a limited intervention type method would increase these adherence rates. So this leads me to the purpose of our study, which is to determine the effects of resistance training with resistance bands on maternal birth and newborn outcomes when performed during the 2nd and 3rd trimesters with limited intervention.
To accomplish this purpose, this was the methodology that we used. Our study was a prospective randomized control trial. In order to participate in our study, there were inclusion criteria that had to be met and exclusion criteria that would exclude women from participating in our study. The inclusion criteria basically meant that we needed a healthy woman with a non-complicated pregnancy who had approval from her OB provider at Winona Health. Our exclusion criteria were that we any pregnancy complication leading to early delivery and any previous participation in resistance training. For recruitment, we took multiple different routes. The main way that we recruited women was by the student co-investigators attending their regularly scheduled appointments and discussing our study with them before or after for a short amount of time to see if they were interested. We We also had flyers and brochures scattered throughout Winona Health as well. For the women who decided to participate in our study, we reimbursed them with a Target gift card. Part of our study consisted of 3 different surveys. The first survey was a pre-intervention survey that was taken between 12 and 25 weeks of gestation. The next survey was a post-intervention survey taken between 34 and 40 weeks of gestation, and the last one was a post-delivery survey. The pre-intervention survey collected data on pre-pregnancy physical activity, current physical activity, low back pain, and muscle soreness. The post-intervention survey collected data on current physical activity and low back pain. And the post-delivery survey has 2 questions on upper and lower body muscle soreness from a scale of 1 to 10, with 1 being normal and 10 being very, very sore. For our standard care group, which is also known as our control group, the women continued their normal prenatal care from their OB provider and were given the ACOG guidelines for physical activity. Once again, the ACOG guidelines state that a healthy pregnant woman should perform at least 30 minutes of activity on most, if not all, days of the week. The sole purpose for the standard care group was to complete the 3 surveys and get data to compare with the exercise group. The exercise group was also given the ACOG guidelines and completed the same 3 surveys as the standard care group. However, the women had to commit some more time to the study because they took part in a 15-week exercise program. Within this program, there were 3 sessions per week at a somewhat hard intensity or an RPE of 5 to 6. One of those sessions each week was supervised by the student co-investigators, where we taught appropriate technique, breathing patterns, and any modifications that were needed on an individual basis. The other 2 sessions each week were completed independently, and we contacted them via text message to make sure that they completed the exercises and to see if any questions had come up throughout the week. So this table shows some different aspects of the exercise program that we implemented in the exercise group. We would start out with a short 5 to 10 minute warm-up and move on to the 30 to 35 minute resistance band training session. All the women started at 2 sets of 15 repetitions and were progressed on an individual basis to more sets of reps. The exercises that we had to perform are listed here, including things like hip abductions, seated leg curls, triceps extensions, and pelvic tilts. All of the exercises that we chose were based off of the muscles that are mostly used during the course of labor. And then we would end with a short cool down at the end. The outcomes that we measured fit under 3 different categories: maternal, birth, and newborn outcomes. The maternal outcomes included maternal weight gain, low back pain, and upper and lower body muscle soreness. The birth outcomes included gestational age at birth, the length of the second stage of labor, maternal effort, and mode of birth. Gestational age at birth refers to how far along the pregnancy was in weeks at the time of delivery. A typical pregnancy is usually around 37 to 40 weeks in duration. The length of second stage of labor is from when the mother is 10 centimeters dilated until when she gives birth. And maternal effort is the push time, which is a portion of that length of the second stage of labor, and it's from when the mom starts pushing until when the baby is born. Mode of birth just refers to if the delivery was natural or a C-section. The newborn outcomes included newborn weight, length, and the APGAR scores at 1 and 5 minutes. The APGAR score is an assessment of how the baby is doing at birth, and it determines if they need any additional medical assistance. This quick evaluation is done at 1 minute after birth, and again at 5 minutes after birth. This table here shows that the baby is given 0, 1, or 2 points in these 5 different categories to get a perfect score of 10 for the healthiest baby. In order to complete our statistical analysis, we used SPSS 23, and our level of statistical significance was set to a p-value of less than or equal to 0.05. We used descriptive statistics to analyze maternal height, weight, and BMI. For upper and lower body muscle soreness, we used a change score, and we calculated early pregnancy score minus the post-birth score to get an overall change in muscle soreness. Thus, a positive score showed that muscle soreness decreased, and a negative score showed an increase in muscle soreness. A one-tailed independent t-test was used to analyze all maternal outcomes, the length of the second stage of labor, and maternal effort. A one-tailed test was used when we believed that the results would be lesser or greater in one of the 2 groups. For example, we thought that the length of the second stage of labor would be shorter in the exercise group, so we used a one-tailed independent t-test. A 2-tailed independent t-test was used to analyze gestational age at delivery and all of the newborn outcomes. A 2-tailed test was used when we did not hypothesize any change between the 2 groups, so the results would go either way. All t-tests were used as a way to compare the means between the two groups. Lastly, we used a chi-square test to analyze mode of delivery because it was categorical data. Either the women had a C-section or they did not.
Now we'll be discussing the results that we found. First off, I just want to explain the table. All tables will be set up as so. The first column will be the outcomes that we looked at. The second will be the exercise group results. The third will be the standard care group results, and the fourth will be the p-values. The exercise group was made up of 9 women, and the standard care group was made up of 6. The first table we're looking at is demographic characteristics of our participants. We looked at age of delivery, race, ethnicity, and pre-pregnancy BMI. None of these were found to be significant. All of our women were around 27 years of age, mostly white, with the pre-pregnancy BMI about 25, which is considered overweight. Next, we have maternal outcomes. The first two we looked at, maternal weight gain and low back change score. Neither of these were found to be significant, although our women in the exercise group we found that they gained about 5 more kilos than that of the women in the standard care group. This was somewhat unexpected for us to find this finding, but we further analyzed it, and then this will be discussed later in our discussion. The other two maternal outcomes are upper body muscle soreness change score and lower body muscle change score. As you can see, upper body muscle soreness was not found to be significant, although lower body muscle soreness was found to be significant. This first figure here representing upper body muscle soreness. All the soreness was rated on a scale from 1 to 10. The blue represents the pre-intervention soreness scores reported, while the green represents the post-birth soreness scores reported. As you can see, the women in the exercise group had a decrease from pre to post of 0.89, while the women in the standard care group experienced an increase of negative 1.2 from pre to post. Next, we have this figure representing lower body muscle soreness. As you can see, both groups did experience an increase, although we did find this to be significant with a p-value of 0.02. So, as you can see, the standard care group did increase a lot more than that of the exercise group. Next, we have our birth outcomes that we looked at. First off, gestational age at delivery. All the women were found to be pregnant around 273 days, which is equal to about 39 weeks, and that's the average length of gestation for women. This was not found to be significant. Second stage of labor, maternal effort, also were not found to be significant. The only birth outcome we did find to be significant was that of mode of birth. Out of the 9 women in the exercise group, 8 had vaginal births. We had 0 unscheduled C-sections, and while we had 1 scheduled C-section, while within the 6 women in the standard care group, 2 had vaginal births, 3 had unscheduled C-sections, and we only had 1 scheduled C-section. And that had a p-value of 0.02. Next, lastly, our newborn outcomes. First, weight and length of newborns. Neither of these were found to be significant. All of the newborns were around 3 kilograms, which is equal to about 7 pounds. And the average length of the babies were about 50 centimeters, which is equal to about 20 inches. And lastly, the last 2 newborn outcomes were APGAR scores at 1 minute and APGAR scores at 5 minutes. Neither of these were found to be significant. The average scores for the newborns were around 8 and 9, which are considered excellent scores.
Now I'll discuss what the results mean. I will start with maternal weight gain. The hypothesis was not supported that there would be a decrease in maternal weight gain in the exercise group. While not significant, surprisingly, as Winona said, weight gain did increase in the exercise group. Therefore, we ran a post hoc analysis. We categorized women by pre-pregnancy BMI into normal, overweight, and obese categories. We then compared the categories to the Institution of Medicine for our IOM. IOM is a nationally recognized academy. This is the chart that we use to compare the women And here you can see this is the pre-pregnancy BMI, and this column here is going to be the recommended weight gain. We analyzed women by if they did gain the recommended weight, or if they gained above or below the recommended weight. There was no statistical difference between the exercise group and the standard care group based on IOM recommendations. A study in 2013 found similar results. This study focused on maternal weight gain. If women were overweight or obese, there was no difference in weight gain between the exercise group and the standard care group. Because our women were overweight, the results were corroborated. One possible explanation as to why the exercise group gained more than the standard care group is a change in body composition. Muscle mass typically increases with resistance training, and muscle mass weighs more than fat mass. Therefore, since the women in the exercise group increased muscle mass, they may have increased weight gain because of this. Now I'm going to discuss muscle soreness. Why did we decide to measure muscle soreness? Well, it was a common complaint noticed by Dr. Richards, and to our knowledge, no research focused on upper and lower body muscle soreness. But there are some research that does recommend that there's some research that suggests that it can help with the demands of labor. So that brings me to upper body muscle soreness. The hypothesis was not supported that there would be a reduction in upper body muscle soreness in the exercise group. I would like to point out the direction of the scores on the graph that Jelena explained earlier. As she noted, there was a decrease in the exercise group in upper body muscle soreness, while an increase in the standard care group. Thus, the mean scores were trending in the expected direction. Some possible explanations that we did not see a significant change in upper body soreness was maybe the intensity just was not great enough to see a difference. Another explanation could be the type of muscle action. During training, we did dynamic exercises where the type of muscle action was concentric and eccentric muscle actions, whereas delivery is typically isometric muscle actions, meaning no change in length of muscle. Therefore, the type of muscle action could have influenced the results.
Now we'll talk about lower body muscle soreness. Our hypothesis of a reduction in lower body muscle soreness in the exercise group was actually supported. We found a statistically significant difference between the standard care and exercise group. As you can see from this figure, the exercise group increased much less in muscle soreness than the standard care group, showing that the resistance training program was effective in influencing the lower body muscle soreness. We know this program was effective also because we did a randomized controlled trial study, meaning that our participants were chosen at random, and the women had similar demographics, showing that the resistance training program should really be the only variable that influenced the lower body muscle soreness in the women in our study. Some reasons that the program may have worked are that we chose to do submaximal exercise program leading to the maximal exertion of delivery, which is a common training protocol to cause positive adaptation in competition. For example, marathon runners typically train at a lower intensity or for a lower duration than they do when they actually run the marathon. Similarly, we don't expect our women to train at the same intensity as they would going into delivery. Although this program was significant in lower body muscle soreness, it was not significant in upper body muscle soreness. And we found this interesting because we did similar number of exercises at similar intensities. So why might this have happened? As Evan said, the program may just have been too submaximal. And
Ideally, we may want to increase the intensity of the program. This could be through free weights or through weight machines. However, we saw a very high adherence rate, and in order to keep this adherence rate high, it's important that the women can do these programs wherever, whether that's at home, whether that's when they're traveling. So a better way to increase the intensity might be to increase the resistance of the bands. Now we'll discuss low back pain. Our hypothesis of a reduction in low back pain in the exercise group was not supported. We did not find a statistically significant difference between the exercise and standard care groups. However, as you can see here, the exercise group had an increase in the low back pain, or a positive low back pain change score, which means that they had a decrease in low back pain. Whereas the standard care group had a negative low back pain change score, which shows that they had an increase in low back pain. This means that the values were trending in the expected direction, even though they weren't significant. Other studies that we've reviewed have shown very conflicting results in low back pain and exercise. One review study done by the Cochrane collaboration that looked at 7 different studies with 645 women did find a significant difference between low back pain and exercise. However, they viewed the evidence of these articles as low quality, so it's hard to understand the accuracy of these results. Another article looked at a structured exercise program with strength training and found no significant difference. So we really don't see many conclusive results with low back pain and exercise. One reason that low back pain may not have been affected by the resistance training program is due to the anatomical changes that occur during pregnancy that change the postural alignment of the women. Typically, we would counterbalance these changes through a variety of core exercises. However, as was touched on a bit earlier, there are many safety concerns during pregnancy that limit the amount of core exercises that we can do. As Ashley said, women should not lay on their back during pregnancy because they can push on the main blood vessel to the heart and limit the blood flow. Also, women experience something called rectus diastasis when they're pregnant, which is just a widening in the mid portion of the abdominal muscles. And this gap widens even more when women do motions that are similar to sit-ups. So we can't recommend them to do these types of motions during pregnancy. Due to the safety concerns during pregnancy that limit the core exercises possible, low back pain may just be something that occurs during pregnancy regardless of exercises performed.
All right, now I'll discuss the birth outcomes. The first outcome is mode of birth. Our hypothesis was supported. We thought that there would be an increase in vaginal births in the exercise group, and there was a statistically significant difference. In fact, the exercise group had 0 unscheduled C-sections, whereas 3 of the women started in the standard care group started out in a vaginal birth and then went into an unscheduled C-section. And we think this is due to the increased strength in the pelvic floor muscles, helping the woman in the exercise group to complete a vaginal birth without complications leading to a C-section. Also, similar studies suggest that there is an association existing between exercise during pregnancy and the reduced need for a C-section. And lastly, it's important to note that vaginal births are the preferred mode of birth because of a shorter recovery time, and they avoid surgical complications. And there's also fetal benefits like decreased respiratory problems. The next is the second stage of labor. Our hypothesis was not supported. We thought that there would be a shorter second stage in the exercise group. However, there was no statistically significant difference. And the Bearcat review study discusses the adverse effects that a long labor can have on the mother and fetus. Thus, we wanted to see if exercise could reduce that time. And within that study, the Ruiz et al. Study found no effect of light to moderate intensity aerobic and resistance training on the duration of labor in 481 pregnant women. So just like our study, we performed at a moderate intensity and found no difference either. So the stimulus may not have been big enough to see the change. And also at the same time, there are women in the standard care group who didn't even reach the second stage of labor. Because they went into a C-section, so that's also why there would be no difference. Maternal effort. Our hypothesis again was not supported. We thought that there would be a decreased maternal effort in the exercise group. However, there was no statistically significant difference. And we thought that the increased muscle mass in the exercise group would have helped the woman to push harder and for less time. But while the resistance training didn't change the total labor time, there were still more vaginal births in the exercise group than in the standard care group. There were 8 women in the exercise group who had a vaginal birth, whereas there were only 2 women in the standard care group who had vaginal birth. So that also explains why the push time would be longer in the exercise group. Lastly, the gestational age at birth. Our hypothesis was supported. We thought that there would be no change in the gestational age at birth between the groups. And there was no statistically significant difference. However, it is clinically relevant because it showed that exercise at this intensity and this type of exercise didn't harm the maternal and fetal unit, so it didn't cause them to have an early delivery. And it's also corroborated by a review study that found moderate intensity exercise did not lead to earlier births in healthy pregnant women.
Now I'll be discussing the newborn outcomes. The 3 newborn outcomes that we studied were the newborn weight, newborn length, and APGAR scores at 1 and 5 minutes. For all 3 of these outcomes, we hypothesized that there would be no difference in the standard care group with the newborn weight, length, and APGAR scores. We found that all 3 of these were not statistically significant, so our hypotheses were all supported. These were the desired results to show that resistance training was safe for the maternal and fetal unit. There were no signs of hypoxia, hypoglycemia, or hyperthermia, like Ashley had previously talked about. Some studies that we looked at prior to this, we found that they produced similar findings. All 3 of these programs performed about 2 to 3 days per week of aerobic and/or strength training during the 2nd and 3rd trimesters, and for them to find similar results that there were no differences in the 2 groups between newborn weight, newborn length, and APGAR scores show that and reiterate that resistance training does not have any adverse effects on the newborn outcomes.
Now for the limitations of our study. Our first limitation is our small sample size. Initially, our goal was to recruit 50 women, but because of the limited amount of women in the correct trimester, we were unable to obtain that goal. And also, we limited ourselves to just the city of Winona and specifically Winona Health Hospital. The second limitation is that we had a homogeneous sample in nature. Therefore, our population is not generalizable to the entire population. And lastly, the self-report surveys. With that, there could have been errors in the answers, and also questions could have been perceived differently.
There are multiple strengths in our study. One of the first and most important strengths is that we use a randomized control trial, or an RCT, because it is the strongest study to design and improve validity. Another strength is that our exercise program strictly focused on resistive training. The Bearcat group is the only other people we are aware of that has solely focused on resistive training during pregnancy. The women in our exercise group had an adherence rate of 98%. On average, women performed 45 exercise sessions during the 15-week intervention. By utilizing the limited intervention, it was easier for women to implement the exercise program into their daily lives. We are also still able to build personal relationships with the women throughout the intervention. Women were also able to progress at an individual basis, and the program was cost effective, all of which we believe led to the high adherence rate. One of our last and most perhaps most important strength is that our study design created the exercise protocols to keep women active during the 2nd and 3rd trimesters of pregnancy. According to national surveys, nearly twice as many women are sedentary during pregnancy compared to the national average U.S. adult. Among women who are pregnant during an exercise, physical activity tends to be of lower duration, frequency, and intensity compared to the pre-pregnancy levels. In conclusion, the results from our study has shown that performing resistive training during the 2nd and 3rd trimesters of pregnancy has improved lower body muscle soreness, and there is seen to be an increase in vaginal births. There are no adverse effects on the maternal, birth, and newborn outcomes. Therefore, we urge practitioners to prescribe our exercise protocol to pregnant women immediately as a safe, inexpensive, and practical way to keep pregnant women active during the second and third trimesters of pregnancy and reduce lower body muscle soreness after birth. We would like to acknowledge Dr. Erin White and Dr. Melissa Richards for their guidance, leadership, and support through this entire process. We would also like to acknowledge Winona Health healthcare providers and staff, and the WSU Foundation for their financial support. Our references are available here. Thank you, and are there any questions?
In your presentation, you said that it's not good for the pregnant women to lay on their backs during pregnancy. Is that just for exercise, or is that also like at home when they're actually trying to sleep? Because what other position would they sleep in? I mean, because they can't sleep on their stomachs, and also relates to like SIDS when the newborn is.
It is at all times. It's not just during exercise. And one way that they can sleep is, they can go onto their sides, whatever side is more comfortable for them. But supine is during all times of daily life. It's not just during exercise.
However,
We'll say, educate yourself.
so I see women throughout their pregnancy, right? So what I tell my patients is you can't control when you sleep, right? So what I tell women, you're going to reach a point where you can't. So those in the audience who have had a baby before, you reach that point where you can't do that anymore, and you're just unable to. I joke with my patients that they can do the trick that we use with sleep apnea people and put the little tennis ball on their back. Yeah, but no, I don't make anyone do that. So the goal is we don't do sit-ups, but the first trimester, if you're waking up on your belly or on your back, that's fine. You're just not going to be able to do it in the future. But you're spot on. You don't want to be on your backs.
You guys said that the maternal effort time didn't change at all. How long is the typical time?
Okay, so the typical maternal effort for a normal pregnancy is different based on whether or not it's their first baby or their second or more. So the typical time for a first-time mother is about 2 hours with no epidural, and 1 hour if they've had more than one child in the past. And if you have an epidural during the pregnancy or during the labor, you add an hour to the typical push time.
Hi, first of all, congratulations on your research. I have a question about the pre-existing condition. So if a mother has something like high blood pressure or obesity or like a previous cesarean section, with exercise, do you think it would have a positive effect on the decreased need of an unscheduled C-section?
I'll take that. So, remember, our study, we wanted uncomplicated individuals in our study.
Right.
However, I encourage all pregnant women 20 to 30 minutes, and ACOG just came out in their green journal yesterday. I received in the mail, they have reaffirmed their position on exercise 20 to 30 minutes every day, most days, if not every day of the week, exercising. And we do know that the hope is to decrease risk of those pre-existing conditions. VBAC, or vaginal birth after cesarean section, or history of previous cesarean section, I would use that in a different category, but history of gestational diabetes or diabetes, high blood pressure, any of those comorbidities, we would still encourage exercise.
Even during the first 15 weeks, if you were previously sedentary, the old ACOG guidelines kind of suggested maybe you shouldn't do that, but that's changed.
So ACOG, I don't want anyone to start, ACOG supports no one starting marathon training at their first OB visit, but we do encourage all women, regardless of their previous exercising, to do the 20 to 30 minutes on all, if not most.
Has there been stuff to show that if you exercise more than that, it's bad?
No. So, like many things in obstetrics, I can't take a group of pregnant women and say, you ladies are gonna run until you puke, and you are gonna do light exercise. So there's no data, no randomized control studies or anything along those lines. So we just encourage women to exercise at 20 to 30 minutes, as I've said. But if you notice contractions, Braxton Hicks, so I tell women when you're going for a walk, you need two things. You need a cell phone and you need water, okay? So you need to stay hydrated, and you need getting from point A to point B, easy, point B to point A, not always. So you need someone to pick you up if you need that.
Alex?
I have another question about possible limitations. Say, did you guys look at their everyday actions if they, say, went to work still, or if they stood up all day or sat? Would that be considered to be a limitation for back pain, etc.?
We had the survey that we had the women complete for their physical activity, their current physical activity, and their pre-pregnancy physical activity was the PPAC, the pregnancy physical activity questionnaire, and that answered, they were asked questions about like, how much time do you spend feeding a child, how much time do you spend on your feet at work, like those kinds of things. So we got that data from those surveys.
The other thing I would say, so we did look at that, and this is part of the data that's still being analyzed. But you can see here, so blue is pre-pregnancy, green is early pregnancy, so right around that 12 to 25 weeks when they entered, and then trimester 3. So you can easily see, right, women drop in activity levels from pre-pregnancy even to early pregnancy, and then even more so in trimester 3. So that's something we're still looking at, but it definitely plays a role. Dr. Costello and Dr. Geyer. Riley.
I'd just like to clarify, did you say that isometric contraction is the predominant contraction during labor?
Yes.
Do you guys think that you would have benefited from including isometric contraction in your exercise program?
We think we might have as far as during delivery, but we felt that the dynamic contractions that we were doing were better for the functional daily life activities. So that's why we chose to use those.
Also, breathing, trying to avoid holding the women holding their breath. That's consideration.
You said a limitation was your number of women that you had in your study. Do you think, based on your research, having more would have skewed your results at all?
It's a randomized control, and that's about as unbiased as you can get. We will be having a few more results coming in, but I mean, to our knowledge, we've seen no reason